right, well, good afternoon, everybody. Welcome to Clearview. I'm so glad y'all are here. My name is Emily Russell, and I'm the Director of Marketing and Business Development here. And one of my favorite parts of my job is that I get to host these Lunch and Learns events every single month. So this month we are talking about esophageal cancer and learning about what are some of the signs and symptoms, what are some preventions that you can do, and what are some treatment options as well as some of the resources that we have here at Clearview to treat that. And then next month we will be talking about the onset of dementia and how to recognize the signs of that, symptoms, all those kinds of things. So you guys be sure to mark your calendar. I believe it's May 19th off the top of my head. But you can always call that phone number that you call to register or visit our website to find out more. So today we are so excited to have with us two University of Georgia students that are both seniors, and I'm gonna let them tell you guys about themselves and a little bit about kind of how they came to here, and they're actually going to be doing the presentation for y'all. So without further ado, I'm going to turn it over to you guys, okay?
All right.
Oh, hi, I'm Quinaria Streeter. Like Emily said, I am a senior at the University of Georgia, and me and Matt both are, so we'll be graduating in May. And we are both health promotion and behavior majors. So our major really focuses on keeping the community healthy, work sites, school children, all of that. So we do whatever we can to promote health within our communities.
And I'm Matt Culberson. I go to UGA, 4th year. And we're both health promotion majors that focus on improving the health of the community as a whole. And right now we're waiting grad school. We're awaiting to hear back from them to see if we got into our master's program. So that's where we're at right now. We've had a great 4 years. And now we're going to tell you a little bit about esophageal cancer, okay?
Okay, so before we start talking about the cancer within itself, we're kind of going to just go over like the normal anatomy. That way you can better understand the consequences of if this normal anatomy malfunctions in any type of way. So the esophagus is basically just a muscle. It starts at the back of your throat and goes all the way to your stomach. And basically this is just the muscle that helps propel food from your mouth down to the stomach. And liquids go through this as well as food, and it reaches the stomach, but it is controlled by sphincters, both at the top of the throat and at the bottom of the stomach, to allow food not to respire and come back up through the esophagus to stay down in the stomach. Okay, so this is, if you kind of cut the esophagus in half, this is kind of what it would look like. And the esophagus is lined with different layers. And these layers are there to basically lubricate the esophagus, help the food go down easier, and also just to provide cushion and added protection just in case you were to get hit there or in case you swallow something so it doesn't easily puncture the esophagus or something like that. And so the inside of the esophagus is called the lumen, and that's where the food is going to touch. The outside layers are just there as protection layers. And the main layers that we're going to talk about are the mucosal layer, and that's right outside of the lumen, right there in the picture. And then the next layer outside of the mucosal layer is the submucosal layer. And so those are the two main layers that can have cancerous growth on them. And that's actually what esophageal cancer is the cancerous growth is on those outside layers of the esophagus, not necessarily the esophagus itself. Okay, so the mucosal layers, like I said, is the first layer that lines the esophagus, and it's actually made of 3 smaller layers within that layer, but those aren't that important, so we're going to skip past those. And then the submucosal layer is that next layer, and that's a layer that contains a lot of blood vessels, a lot of nerve endings. So you could imagine if you have a tumorous growth or something like that, it's going to be really painful in that region. Okay, and the mucosal layer, this is also where the cancerous cells can grow, and the cancerous cells are going to start on that layer and grow inward. So it's going to be painful to swallow because that cancerous growth is going to start from the outside and go further inward, basically closing your esophagus gap, so it's harder to squeeze food and liquids and things like that down there. So the mucosal propypia is the thick layer of muscle outside of the submucosal layer, so that's the layer of muscle that helps protect that layer of the submucosal. And it pushes food from the esophagus to the stomach, like we said before. And the adventia is the outermost layer of the esophagus. And so that's another layer that can be affected with cancerous growth. So as you can see in this picture, we all know that cancer is kind of like in 4 stages, not so bad to really, really bad. And so right here, it's just kind of showing how the cancerous cells can grow in the esophagus. So if you look at stage 0, you kind of see a little bump that starts on that layer. And like I said, it grows, as it gets bigger, it grows inward, basically blocking your food passage and things like that. Okay, so there are 2 main types of esophageal cancer. So those main types are the squamous cell carcinoma and the edema carcinoma. And those are basically just the cancerous tumors growing on those specific layers. So like we said before, and other rare cancers are there, but majority of the cancers that you hear for esophageal are going to be the squamous cell and the edema carcinoma. Okay, so as we can see with both of the cancers, there's really no way for you to tell the difference between which cancer you have, but as a physician, they can look in more closely and tell which type of cancer you have. But essentially, this is how both of the cancers are going to look. And the squamous cell carcinoma, it's important to know that that cancer is a lot more prevalent in African Americans. So that's an important tip to take from that one. And this used to be the main form of cancer, but with technology and with medication, it has become the second most common. So, and this is the most common one, the edema carcinoma, and that's the one that starts in the glands of the layer, of the mucosal layer, and it just, like I said, it starts in that layer, and the cancerous cells grow outward towards the center, affecting how you swallow.
All right, guys, now that we've gone over the anatomy of the esophagus and how the inner workings of that go, do we have any questions about that before we move on? No? Okay. All right, so as we move on, we talk about what goes right and what goes wrong with that, and let's say the steps we take in our life that will change those factors, okay? So here we have the stages of the esophageal cancer right here. All right, and then it goes in increasing order from, best to worst. In stage 1, that's basically describing a cancer occurring in the superficial layers. Superficial just simply meaning the top layers, okay? And that, if we catch it there, that's great. And that's a job of doing some screenings, taking the proper measures there to catch it in stage 1, hopefully before it gets to stage 2 or even stage 4, okay? And then in stage 2, when someone says stage 2, that simply means that it's going down deeper into the layers, okay? So it goes into like the lymph nodes nearby, and once it hits the lymph nodes, it begins to spread throughout your neck's tissues, and it begins to take a broader range throughout your body. And then once it goes throughout your body, we hit stage 4 in the cancer. Okay?
And it's important to note about stage 4, that's really the stage where there are not many treatments available, because that's when the cancer is no longer just in the esophagus, it's moved to other parts of the body. So it's pretty much impossible to get rid of it.
It's hard to target it once it gets there. You can't just, we have our treatment options, which we'll go over later, which may be surgery or attacking it with some sort of radiation or chemotherapy. But once those agents spread throughout the body, it's hard to just target it right here, okay? Because you've got it here and you've got it here too, okay? So let's go over some lifestyle factors that may increase or decrease our chances of getting esophageal cancer, okay? That's the main reason we're here today. We want to be able to prevent that and stop it right now, okay? So cancers that start in the esophagus are much more common than in men. Much more common in men than in women. It's 3 to 1 actually, which is, that's not good for us guys. Okay, so we have to understand that, know it, and take extra caution and extra preventable measures. Okay? Many of these cancers are in fact linked to tobacco or alcohol use, as well as being overweight. Okay? That's the same as with a lot of cancers. Tobacco and alcohol are your number 1 leading risk factors. Not saying, you need to just cold turkey cut it out immediately, but if we can wean off that throughout the future, that would be our best bet.
Okay, so next we're going to talk about some more risk factors that increase your chances of developing esophageal cancer. And being older than 55 is one of the main risk factors. But that's something we can't help, but as long as we try to do other lifestyle behavior changes and make sure we're up on our screenings, then we can kind of fluctuate our results for that one. And so somebody mentioned that they had the Barrett's esophagus. So basically that relates to the next one that we have in bold, which is acid reflux. And so what acid reflux is just when you burp, it's just the acid from your stomach burns the lining of the esophagus. Because the acid in your stomach that's there to digest food is about a pH of 2. And that's really, really low on the pH scale. So it's really acidic. And therefore it burns the lining of the esophagus, and it kind of damages those cells there and make them more prone to not being able to regulate their division, which leads to cancerous growth. And improper diet, like Matt just said, obesity is a risk factor for esophageal cancer. And lye, that's a chemical in a lot of workplaces, and it's also in a lot of hair products, relaxers and things like that. So it's trying to stay away from things like that. Like Matt said, a history of smoking, which can lead to throat cancer and lung cancer too. That's also a risk factor. And HPV, if you've ever had HPV, that also is shown to increase your risk for esophageal cancer.
What is HPV?
HPV is human papilloma virus, and that's mainly transmitted through sexual contact.
All right, so now let's talk about some changeable factors, what I began to go into earlier. Let me ask you, and we'll have a discussion here, what are some preventative methods or some lifestyle changes, we may have already discussed them, that we could make in order to lower our risk of esophageal cancer? Anybody have an answer with that?
Fresh vegetables and fruit, that's what they say.
Yes, ma'am, you're exactly right there. You're exactly right. Those do not have the carcinogens that other foods that sometimes may taste a little better, they don't have those same carcinogens in them. Okay, so fruits and vegetables we always want to get a lot of in our meals. We place a high importance on that. Do we have anything else that we'd like to add? Exercise. Definitely. We definitely need to get exercise, because what does exercise do? It prevents obesity. We keep the endorphins going throughout our body, okay, which make us feel better each day. So preventing that obesity also puts a lot less strain on the esophagus and on the stomach, and on, a less likelihood of the acid reflux that Q is describing. Okay? So let's say that we're older than 55, okay, so we've got that risk factor, and we may have a little bit of alcohol or tobacco here and there, okay? So we need to know when to take these screening measures to know what we need to do in the future and where we actually stand. Okay, so these screening measures, there is one in particular, it's called an endoscopy. Now some of you may have already had an endoscopy, okay? The endoscopy, basically your doctor will pass a tube down through your throat, okay? It'll go into your esophagus, and it's got a camera on it, and it will look at what's around, okay? And I mean, it's amazing the technology that we have that we can do that. But we can go into our esophagus and look for cancerous cells, and we can tell the cancerous agents by the discoloration of the actual cells and the scarring of the throat. And the thing is, that's a major screening measure that we need to be looking at, because the acid reflux is really key here, because we can tell the early scarring and how it's going to lead, because we have all these previous cases that help us with that. Okay, so we know where it's going to go from there. So the number one, important that I'm trying to say here is to let's get out there and get those endoscopies. Let's make sure we're taking the proper screening measures so we know where we stand, and we know we can take the preventative measures properly.
Does that extend to the stomach?
Yes, sir, it does.
It does.
Now, a biopsy, some of you may have heard of biopsy. Now, that's in a lot of different, that's a lot of different surgical measures here, and it's a test done on any part of the body. It's when they go in and they actually remove some of your tissue, and they take it into the lab, and what they do is they look at it there to see a little bit more in-depth of it, okay? A little bit more in-depth look than what we can get from the tube that goes through your esophagus, okay?
In the, doing an endoscopy, is there an age? I know a lot of doctors won't do a colonoscopy after a certain age. Is there a certain age that a lot of doctors won't do an endoscopy?
Well, I don't know of an age per se, but, it never hurts to get in there and ask them, call them, ask them, and see what you can't find out about it, because as we're talking about here, the important thing to do is to make sure we're taking the proper preventative measures. That's the hardest thing that we as, in this room and we as a culture are having trouble with right now. We're facing the problems of, well, that's down the road, okay? So why do I need to worry about it today? Well, the thing is, when that is today, you're going to regret it, okay? So let's try and take those measures now, and let's do what we can. And, I'll see if I can't find out about that, if there is a maximum age per se.
And another way to kind of dictate that is, like, if you're over 55, you should probably go get screened. But also, if you just exempt a lot of the risk factors, say you've had HPV, you have acid reflux, things that put you at a higher risk, you can kind of gauge how urgent your screening needs to be by those risk factors.
And the acid reflux, I know we keep referring back to that, with it being such a major cause, with the scarring that it does and the damage it does to your throat. But they have medications that are very cheap, very affordable, that they will prescribe to you, and that will manage that on a daily, and it will take the acid reflux completely out. And, it does. That's great medication. So treatment options we have. Let's say that we've progressed onwards, okay, and we've actually we've been diagnosed with the disorder, okay. Well, treatment options that we need to know and be aware of are chemotherapy, radiation, and surgical options, okay? Now, all of these options will depend on simply your preference. They will depend on the stages at which that cancer is at. As we discussed earlier, is it at stage 1, stage 2, stage 3, or even stage 4? And it will also depend at, where it's at on the region in the body, okay? So let's talk about chemotherapy for a minute. I think we all have a good general understanding of what chemotherapy actually is. It's a drug treatment where we use chemicals to kill the cancer cells. Okay, now the hard part about that is that those drugs can actually harm our body in other ways. But, we kind of take, you're dealing with two demons there, and you need to take one of them out. So some of the side effects that we may face would be appetite changes, digestive disorders, fatigue, and hair loss. Those are the common ones. As we move on, we've got surgical options. Now, in surgical options, we can remove a very small tumor. We can remove a portion of the esophagus if it gets to a certain point where it is too large to remove safely. Then we'll actually take out part of the esophagus right there and sew it together, okay? And then lastly, we can remove part of the esophagus as well as the stomach, okay? And, that's the extreme measure there, but, if it's in your best benefit, that's what we're looking at. And then here's a little bit of statistical representation that can sometimes it helps to know things in numbers, okay? Sometimes it helps to understand a little bit in numbers. The lifetime risk of esophageal cancer in the United States is about 1 in 125 in men. Okay, so it's not the most common cancer, but it's one that, as you'll see in the next stat right here, the rate of living past 5 years once diagnosed is 20%. Okay, medicine is taking that up. It used to be 5%. That was a decade ago. So we're improving there, but we need to understand that 20% still, that's 1/5 of people. Okay, right there. So let me go back to that again. 1 in 125 men, as well as 1 in 435 women. Okay. So, and then guys, if we have any further questions that we may not be able to answer, or we may not be able to find a doctor in here that knows the answer, visit a couple of these websites online. Go to the Mayo Clinic. Go to the American Cancer Society. Visit the CDC website, okay? That's a great one. It's governmental. Or also the National Institute of Health. These are great websites to go and visit, learn a little bit about it, become educated, and make sure that we're taking the proper preventative measures, okay? Let's make sure that we make that a priority. Okay, does anybody have any questions for either of us?
In the 4 stages, at what point might we recognize we have a problem ourselves? Any way we can self-detect it at some point? Obviously, stage 1 or 2, you might not notice anything. But as it progresses, do you have congestion, difficult swallowing? Is there some?
Here's the thing with that. Sometimes it becomes normal to you. Okay? So over time, you're just living with what is normal to you. Okay? So you may not know, even by stage 3 or stage 4, that you have anything, different about you. So what we need to make sure, that's why we emphasize the screening measures so much. Okay? Whether it be with breast cancer, and you take the proper screening measures there. Whether it be with prostate cancer, you take the proper screening measures there. It becomes normal to you. Okay, and you may not understand or even know, even though you're educated about the disease, okay, you still may not know because that feels normal to you on a daily. You may not know that you have a headache or how severe it is. Okay, so that's what I would suggest there, is to just get in there and get that proper screening measure so that we do know and we can find out.
Well, when you have the reflux too, you think that's just normal. I'm gonna
Exactly.
take something for that and just keep going. So,
Yes, ma'am.
and then after a while, then you'll end up with what I have, the Barrett's esophagus.
Yes, ma'am.
So, but that's, but you think it's normal.
It-
I mean,
Acid reflux is very normal. It's just when you don't manage it, that's when it
Right.
can become a problem.
right.
Any more questions?
Yes, ma'am.
Yeah, I have a niece who was diagnosed with gastroparesis
Gastroparesis.
and excessive frequent vomiting.
Mm-hmm.
Wouldn't she be at risk?
Yes.
Also?
Because that stomach acid, because she frequently vomits, that stomach acid is still coming through the esophagus very often. So maybe if she could talk to her doctor and somehow prescribe something to control the vomiting or either the acidity of it, something like that, it would probably help her.
This is going on like over 4 years now.
Okay.
Yes.
She's been hospitalized maybe about 10 times for the year.
Yeah.
Well, I'm sure that since
So
she...
they're giving her stuff, but it's not working like it's supposed to. Or she's, I don't know.
Well, as much as we'd like to, neither of us in here have an MD. So, I can only trust that what that doctor's doing is in the best for her, the best interest for her. But that definitely coincides. Those are what you call comorbid disorders, that with one comes the risk of the other, and it comes an elevated risk. Okay, so since she is doing the vomiting so frequently, as Q says, she's dead on that is damaging. It's just like the acid reflux, but it's coming up a little farther. Okay, so I can only trust that the doctor that she has is taking the right measures there, and furthering and making sure he's doing what he can in her best interest.
And something she could probably do is maybe if she could eat more foods that maybe don't upset her stomach so much, or drink less soda, because caffeine is definitely known to cause you to burp a lot, and even and that extra caffeine in there also makes that acidity in the stomach a lot more acidic. So if she could probably eat foods that are more alkaline and bring her acidic levels down.
Sometimes it's
I understand.
just
Yes, ma'am.
being too tired.
Yeah.
And she's
Or dehydrated,
nothing's coming out.
drink more water,
Sometimes,
maybe
but-
dehydrated or
Yes.
something like that.
And if she drinks like the water, it's not staying down. So you don't know. And they would give her IV meds, but sometimes they don't want to do that.
Yeah.
They would give her the pill, which make it worse because it's not staying down to take care of the problem. So,
Yeah, I would definitely, if you could get to a gastroenterologist, a specialist with that, I think that would be your best bet with that one. Because that is uncommon, and that is a tough one.
thank you.
Ma'am, may I ask your name?
My name?
Ma'am, right.
Oh,
Me,
Yes, ma'am.
Mary Jane Stearman.
Mary Jean. Well, you just reminded me of something. You brought up a great point. Okay, great point right there. Has anyone ever heard about having your esophagus stretched?
I've had it twice.
Okay, it's very common. Okay, having our esophagus stretched is actually important with regards to this as well. Okay, because sometimes we do feel like the food is not going all the way down. We've all had the feeling, okay, and some of us more than others. And we'll take it to the point where we may need to have our esophagus actually stretched. And what that does is, it widens it to where the food will pass down a little bit easier. And over time, you may have to have it, because it's going to contract still, you may have to have it stretched again every 3 years or so. Okay?
Is that done by balloon?
Yes, sir. Yes, sir, it is.
Do they stretch, do they stretch the whole esophagus down or just part of it?
Now, see, that right there will all depend on the doctor's discretion, and back to the endoscopy, what they have seen once they come in there, where we're at. Okay? That's all, that all depends on them. But what I will say regarding that is that constant food going down like that and then being stuck, per se, or wedging its way down, and the constant strain that you have, it's just like any other muscle in your body. If you have constant strain on your bicep every day, or on your shoulders or on your back, it's going to eventually wear on you, is it not? Okay, well, it's the same concept there, and it's going to eventually wear on your esophagus to the point that it's going to do some permanent damage. So we need to make sure we take the preventative measures there, even though it may feel normal to you that once every 5 meals, something doesn't go down properly. Okay, it may feel normal to you because you've had to deal with that for so long. But what we need to do is make sure we go and we take the proper preventative measures to look at this, make sure it doesn't progress.
The only way this is off, I hope everyone's finished eating. The only way I can get it is to make myself throw up.
Yes, ma'am.
And sometimes it takes 2 or 3 times to do it.
I understand that feeling very well. I do.
I almost had to bring him down here Friday night. He got a piece of cantaloupe long down there.
It scares you, doesn't it?
Stuff in small pieces and chew good. I know that. That's why with chicken and beef, I've had to go to the hospital once before with some beef hugging my throat on Christmas Day.
And it scares you, doesn't it?
Yes, it does.
Well, I know old country remedies to eat bread.
Well, we tried
I've
that.
tried the bread.
Doesn't help.
We even had soda crackers.
I've tried soda crackers.
That makes it worse.
Finally,
Well, I think because the cantaloupe was so, it broke apart finally,
Because I
because
can
it
see
was
pieces
soft.
start coming.
Yeah, so finally, he was able to get rid of it, but it finally went down, but
I mean, I know that feeling all too well.
I was getting my kitchen cleaned up so I could take him to the hospital.
Oh my goodness! On Christmas Day, I'm so
Well,
sorry.
this was just Friday
Oh, this was
night.
Friday.
This was the last one with the cantaloupe. This was just this past
Well,
Friday.
we may want to go get that looked at.
Well, he's got to.
I've got to.
He's probably gonna have to have it stretched again. He's had it stretched before, so.
And that's okay. Is we need it. We need it.
She has
What about mineral
scleroderma and that goes with it.
Do what now?
Mineral oil.
Mineral oil.
That'll smooth everything.
She is right about that.
Stopped up, it don't nothing go back.
Not even
It's
water.
gonna come right back.
Uh-huh.
Yeah, in the water, it goes in, and then it'll lay there, but then eventually you're gonna throw it up. That's it.
I will tell you 2 things that help me are to stay calm, because you don't want to feel, anxious, and all of a sudden, as we start sweating and the heart races, and we get worried because it's terrifying. It scares you because there's nothing you can do. There is literally no one that can help you right there. And in that situation, you have to remind yourself time and time again to stay calm. Do not become flustered, okay, as hard as it may be, and then make sure you tell someone immediately. Tell someone, and even, this, you may find this hard to believe, but you can perform the Heimlich on yourself. You can grab a chair.
I've tried, but I couldn't never get it up.
Oh, I understand. But you can grab a chair if you need and wedge a chair right here. That's one of the more common ways right now. You just grab a chair with a back on it, and you try to wedge it up under your rib cage.
Can you do that with a pacemaker?
I would think so. Yes, ma'am. Now, I'm not sure about that. I can find out for you, but I would assume you can.
Because I had one of those, so.
She has scleroderma and it's choking
That's
goes
the
with
same
it, they say.
Yes, sir.
You might want to show everybody the international symbol for choking. Yeah. So if you ever see it or need to
anything
do
like
it.
this.
Because sometimes we can't talk.
Yeah.
And that's a very good point. Sometimes we cannot talk, and the international symbol for choking is right here. We want to make sure we get that message across and get it across quickly.
So how does patting somebody on the back help?
You know, it all depends, okay? That motion right there, when you pat somebody over the back and you bend them over and you hit them right here, you don't want to hit them with the palm of your hand because that just hurts. Okay, we don't want to do that. You're hitting them right here with the base of your hand, okay? Because that's a firm tap, okay? And, you know, you bend them over and you want to make sure you're directing it outwards. You're not directing it down because your esophagus, I mean, it's a tube. Okay, we're not directing it down to the ground. We're directing it outwards. Okay, now we want to first always try the Heimlich maneuver. Okay, but if you see that that may not be working or that someone, you know, you're just too small for that person, then we resort to other measures. Okay, we resort to you know, calling. We want to call someone, especially first thing we call someone. We call 911. We do what we can there. You know, secondly, if we see that we're not properly fit to handle the situation, we let somebody else in to handle the situation. We do what we can to help them right there. Okay, and if we do resort to tapping them on the back, we want to just make sure that we're using this right here, palm of our hand,
The heel.
the heel of our hand. That's what I'm looking for, the heel of our hand. And
The
we're
idea is to
directing
get
it
up,
outwards.
Not to go down, right?
Yes, sir.
Okay.
Yes, sir. Yes, sir. Because down, we've already tried. We've already tried with the water, with the bread, the mineral oil. We can't get it to go down. So,
And
We
then
got-
just most important is blocking the airway, most importantly. So you want to just hurry up and get it out so they can breathe. Because most of the time when you're choking, you can't breathe.
guys, can we answer any other questions for you today?
Any recommendations on how often you should do the endoscopy, age-wise?
And that'll be after 55, okay, roughly. After 54, that's not going to prevent you. We use that as a recommendation. Okay, so it's going to be after 55. And then what we're going to do from there, let's say we go and get it when we turn 55, okay? We're going to go get it looked at, and then all it's going to depend on from there is what your doctor tells you. Because each of us are different. Our esophagus are different. And, I mean, it's going to depend on their recommendations from there because they can actually see it. They actually see with that tube what's going on and how often you may need to be looked at because you might be on the verge of something here, you know, or you might be on the verge of something. They tell you to take some preventable measures because we hadn't been doing it lately, and you start taking them and you don't need to come back, okay?
Well, can the doctor make a diagnosis, like, just by looking at you, I mean, looking at your throat and everything, without doing the endoscopy?
He can make a slight diagnosis, okay? And it all depends on the doctor, okay? He can look down your throat and he can see any sort of scarring, and that will be altered to the degree, okay, of which it may be harmed or scarred. Okay, so if it's up here and they can see it here, you know, you need to get something else done as well, and they will tell you the same thing.
And they're not going to make a decision just based off looking at it. They're going to look at it, and then if something looks suspicious, they'll probably do a biopsy and send it to the lab because they don't want to give you a false
That's
positive.
eventually, but
That's definitely the last thing they want to do
Is
is
the
scare you for
preparation
no
for the
reason.
endoscopy similar to colonoscopy, avoiding the intestines, everything?
I would say they put you on some sort of diet. They put you on some sort of, you know, they'll have that pre-op appointment, and they'll put you on some sort of diet recommendation for like 3 days before then or something like that. Well, all right, guys. Well, I hope y'all had a great meal. Maybe learned something today. I don't know, but thank you for coming.